Good afternoon, everyone, and welcome to our webinar, Artificial Intelligence in Medical Education, Opportunities, Risks, and a Future Research Agenda. I'm Jennifer Kogan, Vice Dean for Undergraduate Medical Education, and I will be moderating today's discussion. We're thrilled to have all of you join us for what promises to be an engaging and thought-provoking session. This session was collaboratively created by the School of Medicine, Eileen Rosen in the GME office, as well as Eric Bressman and Gary Weissman in LDI. And today we'll be exploring how AI is transforming medical education, the challenges and opportunities it presents, and what the future may hold. We're hosting this session because artificial intelligence, as many of you know, is rapidly transforming healthcare and education. And for medical educators, AI brings both exciting opportunities such as personalized learning and improved assessment, and significant challenges, ethical considerations, bias mitigation, regulatory and policy implications. Today's discussion is about understanding these dynamics and shaping a thoughtful, evidence-based approach to integrating AI into medical education. So our panel today brings together leaders in medical education and innovation. We have three panelists: Dr. Holly Coretta-Wire, Clinical Associate Professor in Emergency Medicine and Associate Dean of Admissions and Assessment at Stanford University School of Medicine; Dr. Brian Garibaldi, Director in the Center for Bedside Medicine and Professor of Medicine at Northwestern University Feinberg School of Medicine; and Dr. Verity Shea, Assistant Dean for Education in the Clinical Sciences, Assistant Director of Curriculum Innovation, an Associate Professor of Medicine at the NYU Grossman School of Medicine. I'll ask our three panelists to join me now. Welcome, everybody. And we'll begin by, I'll ask each of them to just introduce themselves a little bit more personally, and then we will begin our questions. And so, Holly, I'll start with you.
Thank you all for having me this morning. Holly Coretta-Wire. As Dr. Kogan said, I am Associate Dean for Admissions and Assessment at Stanford, primarily thinking about using AI in both of these spaces, but really to augment our selection processes to ensure that who we're bringing in is really aligned with our mission, and then looking longitudinally at who we bring in and their success in our curriculum from an assessment perspective.
Great. And I know we'll dig into a little bit of that in a little bit. So Brian, welcome.
Thanks so much for having me today. My name is Brian Garibaldi. I'm a professor of medicine at Northwestern University, where I direct our Center for Bedside Medicine. Center started about a year ago, and the real goal of the center is to think about how we combine traditional clinical skills, history taking, physical exam skills, with emerging technology. And when that journey started for us about 10 years ago, with our Society of Bedside Medicine, the technology we were really thinking about was point of care devices, things like digital stethoscopes, point of care ultrasound, and now obviously thinking about how AI can enhance both the way that we teach at the bedside, but the way that we assess the impact of those educational interventions. So super excited to chat with you about some of our thoughts here, but mostly to learn from everyone else as we all explore this new world together.
And last but not least, Verity.
Thanks so much for having me, Verity Shea. So my roles are mentioned, but kind of what I do in those roles, I really oversee our clinical curriculum and a program of assessment for our undergraduate medical education. So really thinking, it's like, what does it mean to train physicians in this era, and how AI can be transformative in both teaching and our assessments. And then I also do deeper dive in education research, specifically within AI and clinical reasoning, and how AI is transforms how we think about teaching clinical reasoning and an assessment of clinical reasoning. And so excited to talk with you all today.
All right, well, maybe we'll begin. And so one of the first things that we've been thinking about as AI becomes more prevalent in medical education, for each of you, are you optimistic or pessimistic about the role of AI in medical education? And tell me a little bit about why. And maybe Holly, I'll kick off with you.
So I will go with cautiously optimistic. And There's a host of reasons for that. And I think the biggest one for me is that I see AI's potential in augmenting what it is that we do. I think a lot of people are very worried about it replacing, the diagnostic skill set, the clinical reasoning of our trainees. And I think just like and I think Brian will get to this probably, all of the other emerging technologies we've experienced, point of care ultrasound, for example, I'm an emergency physician. It has not replaced the physical exam at the bedside. It has augmented the physical exam at the bedside. I think AI similarly has the potential to augment clinical reasoning skills, assessment, teaching. Our learners use it to augment their study habits. So I think it has a lot of great potential if we train our learners to use it and our faculty to use it in a responsible way.
Okay. Brian, what are your thoughts?
So those of you who know me, I am an optimist. I've always been an optimist. I think AI has the potential to refocus some of our efforts in education on some of the skills that really matter. As we start thinking about how to use large language models to assist in clinical reasoning, the more you use these models, the more you realize that's the inputs into those models that really make the most difference and are the most important. And sometimes we think of those inputs as being sort of hard objective data like vital signs or laboratory tests. But during COVID, we all learned that many of those seemingly objective data are truly biased, right? So the best example of that in my own clinical experience and work is pulse oximetry, where it spits out a specific number, and that was the target that we used in order to decide who was eligible for oxygen therapy, remdesivir, other immunomodulatory therapies. And we know that we missed hypoxemia, particularly in patients with darker skin. But the other data that I think we need to put our attention on is the things we've been working on here at our center are the way we speak to patients, the information we gather from patients, our ability to observe and identify physical signs and findings. Those become increasingly important as large language models help us in the clinical reasoning process. And so I think I'm really excited because AI, in my view, is going to shift our attention to the importance of those skills and the need to make sure that we're adequately training our junior physicians and future doctors in the ability to acquire that data. And we have a lot of work to do in that area. We know that physical exam skills in particular are in decline. We know that the most common mistake that's made in the physical exam is simply that it's never been done. And if a tool like this that has, a 3-lead EKG and an AI algorithm that can help you determine if someone's in sinus rhythm can get us excited to go back to the bedside and to get us spending more time with patients. I think it's going to make the experience better for our patients. It's going to make the experience better for us and our trainees. And I think healthcare delivery will be greatly enhanced, but we have to do it in the right way. And I'm sure we're going to talk about all the potential pitfalls that we might find along the way. But I'm very excited about how it's going to drive attention to what matters most, which is the person in the bed or in the clinic or in their home, wherever they're seeking care.
Verity, what's your take on optimistic or pessimistic?
Yeah, I feel like we needed a pessimist on this panel. Those who know me, I am an optimist in general, but I think echoing certainly the things that Holly and Brian already said. Of course, like we have to think about how to do this carefully and cautiously, which we'll obviously dive into deeper in following questions. And the things that I will add to, and I agree with everything that's already been said, is right. We can't make the underlying assumption we're doing it right as humans alone, right? Like we're not, right? I'm not saying we're horrible at everything, but when it comes to diagnosis specifically, like diagnostic errors are a healthcare imperative. They're a patient safety, priority, and we've tried to chip away at that problem and have only made incremental progress. And the promise of AI, and it's really about the AI human collaboration. And granted, there's some tasks that AI will take over entirely and be autonomous, and that's great. None of us want to write prior auth letters. AI can take that, right? But how can we, help augment our clinical decision making, make it better for, improve our clinical decision making, and that augmentation. Or same when it comes to assessment, right? Like we are not gathering enough data on our learners, right? And the power of ambient AI, not saying for documentation, but for assessment, right? And like all that we'll be able to do of actually getting more meaningful data and feedback to our trainees and our faculty too, right, across full thickness, to make them better. And so there is so much potential here to solve some of the problems that we're not getting right now in healthcare and education specifically.
We have two optimistics and a cautiously optimistic. But I think you've all hit on some important ideas around, AI augmenting and not replacing. Brian, the importance of inputs, maybe getting back to the bedside, and Verity, like we might not be doing this so great right now, and this could be an opportunity to improve patient care. Which leads me to kind of one of my next questions, which is around, I think all of you have mentioned things like critical thinking and clinical reasoning. Like, how do you think that reliance on what will impact clinical reasoning and critical thinking for the current generation? Either in like how we think about teaching it or how they're using it. What are your thoughts? And maybe Brian, I'll kick this one off with you.
So I think it's an important opportunity to remember that, at the core of clinical reasoning, clinical reasoning starts with data gathering and data acquisition, right? And so I think it's great if we're using clinical reasoning tools to help us to ask the right questions, to help turn our attention to what might matter in that particular moment for that particular patient. So for example, Courtney Reamer at our Center for Bedside Medicine, she created an app it's a prototype, but hopefully we'll be ready to release it soon, that will actually take information from the history that's in the electronic health record, or you can add supplemental things to it yourself. And it will help you understand what are the diagnostic possibilities. And in that moment, in that room with that patient, what are some high yield things that you can do? What questions can you ask? What maneuvers can you do on physical exam? What signs can you look for? What ultrasound technique might, be called into play that will help you determine the likelihood of specific diagnostic possibilities? So I think if we use the tools and remind ourselves that clinical reasoning starts with data acquisition, then I think we can use these tools to help focus our attention on what matters most to that patient in that moment.
Verity, your thoughts?
Yeah, absolutely. And I think just to, I guess, give the pessimist point of view or the concerns here, it's certainly the concerns around de-skilling and negative never skilling. And again, obviously the promise of the upskilling, right? Human plus AI is going to be better than human alone. Or again, there's some things that AI alone might be better. I think higher order critical thinking is still is a human plus AI task for now, for the foreseeable future. 10 years from now, is that still the case? I don't know. And, again, there is, though, like the productive struggle, and how much of the productive struggle is needed, because, part of that is you need the critical appraisal of the output, right? As a human, right? And so you need enough of a skill set to know to critically appraise of is this the right thing to integrate into my diagnosis, my differential, my management plan. And so you need to be able to make sure you kind of have developed that human alone skill enough to then have the combined, forces. And so we have to think very carefully of like, when we introduce these tools, granted, like they're going to be using them no matter what. So it can't be like, no, you can't use them because they're using them. So talking about how to use them right. And thinking about our programs of assessment, we're still going to have to probably do like human alone assessments to make sure of depending on the skill, but specifically now talking about clinical reasoning of like, how are you doing as a human alone in this? And then a human plus AI assessment to kind of help maintain, to combat that concerns of the de-skilling and the never skilling. So we're going to have to be very intentional of also how we assess our trainees in this to make sure that we have that augmentation and they have enough of the human skill to then be able to correctly integrate AI into their process.
And I think we'll come back to this sort of idea of like de-skilling, never skilling, and detecting bias. But Holly, other thoughts about this?
Yeah, I'll give a pragmatic example. This came up in our clinical competency committee meeting last week, where we had faculty giving feedback to residents to say, we want you to use AI to generate your differential diagnosis. And several members of the competency committee said, hold on. Do we actually want them to be using it to generate their differential diagnosis? And basically, we just took a time out and I said, everyone take 5 minutes, get all of your angst out about, the use of AI in generation of differential diagnosis. And then exactly like Verity said, I said, they're going to be using it. What do we do to help them use it appropriately? What is kind of the workflow, the thought process? Because, similar to evidence-based medicine, we want them to augment their, clinical reasoning, their diagnostic reasoning. We don't want them to lose those skills or never develop those skills. So to your point, de-skilling, never skilling, but we do want them to learn how to use it responsibly because they're going to use it. So how do we teach them to use it responsibly and then put, guardrails on? Because again, they're going to be doing it. And then the example came up of, well, I had a resident who put in, some sort of prompt for their differential diagnosis, came up with something wildly inaccurate, and then went back and said, okay, well, this is what you came up with. This isn't correct. So what was the prompt you put in? How can I help you edit that prompt so you actually get what it is that you're after? And that was just a good opportunity to say, well, this is the kind of stuff that we're going to have to be doing to teach our residents to appropriately use this in the clinical space. So the reality is that it's here, it's training the faculty and the residents to actually kind of have that co-productive moment of, how do we put this together such that we're using it responsibly and we're getting out of it what we want and need without having it harm either the patient or the resident's education.
Maybe speaking along those lines about teaching learners how to use it well and responsibly, I'd be curious, and I'll open this up to anyone who wants to answer, like how we should be thinking about teaching our trainees to either detect and mitigate algorithmic bias or just the recognition that the way that these large language models work is by word association. And so how do you suggest that we be teaching our trainees and maybe even our faculty to direct algorithmic bias? Verity, do you want to go first? And then
Sure.
maybe
Yeah.
Brian.
Yeah. Yeah. I mean, and I think there's nothing I mean, yes, I think it's talking about generally how these technologies work and some of those those limitations, but there's nothing like getting people hands on and experiencing it themselves and with whatever use cases that are most relevant to them. So whether it is a patient care case and helping sort of augment differential diagnosis and management planning, or whether it's an education use case of helping create virtual cases or whatever it might be, and so targeting obviously to the audience of what the use case is, and certainly making sure they understand what these technologies are, but then using it, experiencing it, looking at the critical appraisal and output, and sort of seeing that in real life themselves. And there's actually a really nice framework. This is meant in more for just like clinical care, publication from Raja Ali Abdulnur and Christy Boscardin, and they call it the Deft AI framework. If folks haven't read it, it's definitely a must read. It's like a really practical. It's based on, those might be familiar with kind of like the 1 minute preceptor, like the micro skills framework, and sort of a similar applying to how do you even just talk about AI, like the clinical environment of how did you use this tool? Like what prompts did you put in? How did you critically appraise it? What was wrong with the output, or how did it change your management? And it gives a very practical way to integrate this just in your day-to-day precepting wards, whatever again, this is really more about, it could be applied to non-clinical as well, but your clinical kind of day-to-day, and bring up conversations like that of what are the concerns of potentially bias in this in this output, and it's sort of that's part of that critical appraisal. And so faculty development here is key, right? Because we could do it in our curriculum, in our, whatever it be, GME, UME, in the classroom curriculum up the wazoo. But if they're not seeing and doing this on the wards, in the clinics with their faculty, it's not going to be ingrained of how to do it right. So that faculty development piece is so essential. So there's not the pervasive hidden curriculum here that they're not getting that behavior reinforced in the clinical environment.
Brian, what do you want to add?
Yeah, I mean, I love that point, Verity, that if we're worried about how our learners are going to be using this, we need to be using these tools ourselves, right? We need to be gathering experience in our own clinical practice and our own educational practice so that we begin to understand number one, how you can use these tools, but probably most importantly, where things can go off the rails a little bit and where some of the potential problems might be, both in terms of the prompts that we might be using, but also in terms of the way that we might apply it in certain specific situations. I like to think of this similar to when we go to the bedside and we're talking about a particular patient or we're going through a specific exam maneuver and trying to understand, why is it that we use specific cutoffs for certain tests? So for example, why is our cutoff for spontaneous bacterial peritonitis 250, you know, neutrophils in the acidic fluid? Well, it comes from a test of a few hundred cirrhotic patients who all had alcohol-related cirrhosis in upstate New York. I think it was in the late 70s or early 80s. And they chose that cutoff to make sure that you almost never miss SBP. But the vast majority of people with SBP had over 1,000 neutrophils in their acidic fluid. So we're probably giving some people more antibiotics than some people who didn't have SBP were probably giving antibiotics too, but we're hopefully never missing someone with SBP if we do that analysis. So trying to begin to understand, how some of these algorithms are developed. And I know a lot of this, you can't understand exactly what's under the hood for some of these models, but you can understand the data that goes into them, particularly around, the training data that was used. And I think probably the most commonly talked about example is looking at either radiographic studies. There's the famous study of a neural network that was trained to identify pneumonia on chest X-ray, and it turned out that it just figured out which hospital had the highest prevalence of pneumonia, and it figured out by attending to the little marker that said left or right on the X-ray, it could tell that X-ray Y was from this hospital that had higher prevalence of pneumonia. Therefore, this X-ray probably tells you pneumonia, even though it actually wasn't using any of the information from the lung windows itself. So I think we need to be talking about these things. We need to be using them. We need to be, using clinical reasoning tools on rounds with our patients and with our learners, and being really explicit about where things might go off the rails, and making sure that we talk about the biased data sets that are very possibly going into some of these models.
Verity, you had mentioned, I think, a paper, it might have been by Christy Bosgarden, with a framework. Can you just, a few folks have asked what that is. Can you just repeat again what that is, that reference?
Yeah, and I can also drop it in. I'll drop it in the chat to do one
Okay.
better.
Okay. And then maybe I will ask, there's a question, I think before we move on to the next kind of section of questions, there was a question that came up in the chat, which I do think is related to this idea of kind of clinical reasoning and skilling, never skilling, de-skilling, and sort of what we learn in medical school. And so one of the questions that came up is if medical students, PA students, and NP students all have access to the same AI tools and, are ultimately using these tools in similar ways, what are your thoughts about the differences between the training pathways and kind of, what would or could distinguish those paths? And, when you think about the training time, to become a physician versus some of these other pathways. So just any thoughts about, like, given we're all potentially using these, what that may mean for the profession?
Well, I think this is sort of the age-old question that we continue to come back to, I think, every time a new technology is introduced, right? What is it? What is the core of being a physician, right? And how might that be different from other folks who provide care for patients? And I'm not going to pretend to know all the answers to that question, but I think it's a discussion worth having, and particularly now when we start thinking about, we should be talking about uncertainty a lot more, and the way that we're trained, and the experience that we have that allows us to deal with uncertainty. Because even when all these tools are available, there's always uncertainty, particularly when we go to the bedside and we try to apply whatever knowledge we have to the context of that individual in that moment in time. Um, and and so I think in terms of the gathering of some of this information, and the ability to integrate information into clinical reasoning, that's probably not all that different between different specialties. If you gather the right information, and you understand, you know, the way to integrate that information into a differential diagnosis, that may not be all that different. Where I think the differences might come in, and which get back to what your experience has been along that training pathway, is how do you apply those algorithms to that unique individual in that context. So management reasoning is not something that we talk about as much as we probably should. We're focused a lot on diagnostic reasoning oftentimes when we talk about AI models, because we're giving these models very well curated clinical vignettes. And then we ask them to come up with a differential diagnosis and potentially a management when there's maybe one right answer. But in reality, we all know there's almost never one right answer. The right answer is how that particular management plan fits into a patient's unique preferences and values. And so I think we should also remember that there's more to being a bedside clinician than just coming up with a diagnosis and the right answer. And so I think those different training pathways probably lead to different approaches towards dealing with uncertainty at the bedside. And so I think we just had a big conference in bedside medicine this past weekend in Northwestern, and a lot of our sessions were related to visual thinking strategies, using music to build empathy, these other skills that aren't always about diagnostic reasoning, which is where I think AI is going to be super helpful. It's not going to be helpful with interpreting the meaning of that diagnostic output in the context of that one individual. And so I don't think I've really answered your question, except to say that there are differences in those training pathways that I think probably have something to bear on the way that with a different training set, you might approach that uncertainty that you're inevitably going to encounter at the bedside with a real person.
Holly, it looked like you had maybe some thoughts as well about this.
Yeah, and I wholeheartedly agree with Brian. I think, context certainly matters. And the way that we think about this, at Stanford in the assessment space, for our medical students is, I agree, it's not just, diagnostic reasoning. It is management reasoning regarding, what do you do with the information? How do you adapt to new information? How do you incorporate, the patient in front of you, their desires, their preferences, their context? AI is not going to do that. And not to say that our advanced practice provider colleagues don't do some of that as well, but I think it is the management reasoning plus some of these other things that we think about around systems-based practice, advocacy, interprofessional teaming, the adaptive expertise that we should be training our learners to incorporate into their practice, because they're going to encounter uncertainty not just with the individual patient in front of them, but with encountering things they've never seen before. What do they do with that information? How do they adapt, in the clinical learning environment, but also in their professional life? And so, yes, you see pathways in medical school that are shortening the time to, enter residency training. And there's a lot of benefit to that, to the student, certainly, in taking out, some of the things that are extraneous. But I will say that the scope of practice and the amount of skills our students need to have continues to expand. And so ensuring there are ways that they encounter the things that they need to encounter before moving on to their residency training, like AI, and like being able to incorporate it into their practice in a responsible and reasonable way, while also doing all of these other things, to interact with our complex systems, and the complex patients that in front of them, is going to be ever more important, and a skill set that I don't think is going to be replaced, by AI or replicated in any way.
I think I'm going to shift us to kind of the next sort of set of questions, which is really about how we assess AI's impacts in medical education. And so the question I have for all of you is, we've talked about the opportunities, we've talked about some of the concerns, but how do we going forward assess the pros and cons of AI, recognizing that as a medical education community, we historically have done not such a great job of research on key innovations or changes in education?
I'm happy to take the first stab at that. And I think it's, ever more important that, like, as educators, we're at the table, and, because a lot of the clinical reasoning literature, AI, like AI clinical reasoning literature, is not it's not the focus of some of the articles it's out, so not to put down at all this wonderful work being done, but it's not having the educator perspective of like that might look different, like your outcomes might look different of what is like the best practices of AI's first opinion versus AI's second opinion, essentially like have AI's first opinion, AI outputs what suggestions on differential diagnosis and management, and then the clinician was like, okay, what do I want to do about it, versus like the clinician has to commit, and then consults AI, and that answer might be what is best, might be different for an early trainee who's still developing their skills, needs a bit of the productive struggle. Like there's a lot of in terms of like cognitive load theory that kind of want to get too jargony and like in theory, but like we have to also bring in all that we know from educational theory, from clinical reasoning theory, how we develop skills. And those that are purely like clinical researchers are not thinking about it from that lens. There, a lot of that research is with fully formed, fledged faculty who have theoretically developed their skills. And so we have to be at the table for this research to specifically look at those subgroups of the answer might be different for a PGY2 for an MS3 versus a PGY15 or whatever, someone that's been practiced for a long time. And so we need to insert ourselves into this research, because the answers that come out, what's best for faculty, my hypothesis is that's not going to be the best strategy for the trainee that's still developing their skills.
Holly, go ahead. You muted before I did.
I will say I wholeheartedly agree. I think, we need to be studying this in parallel to kind of normal process in order to really determine the impact of AI. So I'll say in the admissions space, there's been a lot of move toward, let's use the algorithm to predict who we should interview. We get all these applications, let's let an algorithm decide. And you train the algorithm on the prior decisions that you've made. And I think all of us can agree that our prior decisions have not always been 100% correct. And so, a lot of what we've been working to do is really run the algorithm in parallel, see the decisions that AI would make versus the decisions that we would make, and then look at the difference between the two. And then really trying to say, from an assessment perspective, where have we potentially gone wrong in the past? Where are the pain points? Where are the areas in which, maybe we didn't make a decision that was right for, admitting a student who clearly was not successful here, in a whole host of ways? How do we go back and look at that and say, because right now, everything we do in admissions is largely non-predictive anyways, how do we perhaps use AI to generate competencies that are aligned with our mission, with our assessment practices, with what the patients need, as opposed to necessarily what we perhaps the school need, and try to amalgamate that in a way that allows us to, again, try to better predict who's going to be successful here, but clearly study that, because again, we have studies in a lot of spaces and admissions that show us that everything that we do right now is test scores predict test scores. Maybe the MMI predicts, who's going to do well from a clinical perspective, but that you don't get until you choose to interview people. And those interviews are very precious. So how do we actually take this and scale it in such a way that we better predict who is going to, again, take great care of patients, who's going to be competent in clinical practice, as opposed to a lot of what selection is right now, which is replicating yourself and or saying, I simply like this person. And I think there's a lot of opportunity for AI here. But to your point, it's really trying to study the impact of AI and is it actually doing a better job at the selection process, at the assessment process, than perhaps we are in some of these spaces.
Brian.
I think the idea of assessing the use of these tools really provides a broader opportunity to think about the way that we actually assess our trainees, particularly at the graduate level. So I spent a lot of time, with colleagues who work in the UK at the Royal College of Physicians of Edinburgh. And unlike the US, graduate trainees in the UK have to pass a high-stakes summative exam where they have to go through clinical encounters with real patients who have real stories to share and real findings on physical exam. And they do that while being observed by faculty members who themselves had to decide together, these are the findings that are present. This is what I would expect a graduate trainee to be able to assess. And, you know, in the US, we got rid of those style of assessments for graduates or for board certification in the 1970s. And, step two, clinical skills. I know there's lots of, it wasn't a perfect assessment, but now that it's gone, assessment certainly drives attention. We can argue whether or not assessment drives learning. Um, I think this is a really important opportunity to take a step back and make sure that as we're looking at these tools, we're not just assessing clinical reasoning based on what decision did you make when presented with this data. I think we really do need to get back to assessing, are our trainees able to acquire this primary data? And it may be that, in some future state, a lot of that data acquisition happens with an AI companion who reminds you in your earpiece to tell you, hey, you forgot to ask this question based on what we just heard the patient tell you, or hey, you might want to think about, examining the chest, not through the robe, so that you don't miss something, right? And that would be a great future state. And I think AI tools will allow us the ability to do some of these direct observations that are lacking, particularly on the graduate medical education side. But as we start talking about assessment, I do think we should take a step back and say, is it okay that I could be a practicing physician for 20 years and no one in my career has ever actually watched me do a clinical encounter on a patient where they actually had the opportunity to know what the findings were likely to be, unless I asked for that direct feedback. That's the current state of our assessment of clinical skills in the US. And something that I hope that this discussion about assessment of the use of these tools will allow us to take a step back and say, let's make sure that the primary assessments we're doing are not just clinical reasoning based assessments, because that's the ones that are easiest to do using, whatever your decision making in the chart that you can acquire on thousands of learners at once and analyze. So I do think we need to be careful that we don't just fall into this trap of just designing assessments that look at how AI impacts clinical reasoning, but really how does it impact the primary acquisition of data and the way that we apply that data to our patients.
And Holly, I see that you put on our side, which I don't know everybody can see, but that emergency medicine looks like it's bringing back in 2026 clinical skills assessment for board certification, I think, to Brian's point.
Yeah, and anesthesia actually has done it over the last several years. We've actually learned a lot of lessons from them in bringing this back. I'm actually headed there this afternoon to finish writing the exam.
Well, I think it's oh, sorry, Verity.
Yeah, so I was just going to make a quick comment building on that, and I think I mentioned it briefly at the beginning of I think ambient AI is going to be so powerful. Again, not saying as a documentation tool, which yes, it will be, but as an assessment tool, right? And the reason why, right, it's there's just too much pressure put on. It's not that our supervising faculty are not wonderful human beings, but there's too much asked of them. They're not getting the time to get to the bedside and do the direct observation and feedback. But ambient is going to be such a powerful tool for kind of multimodal kind of audio, video, patient communication skills, kind of feedback on where you're placing this, the stethoscope. And so I think that's going to be a game changer for assessment in medical education, is the power of ambient to be able to do that at scale in real patient encounters that we just don't have the time in the day as humans to do the direct observation and feedback of.
And I do think, if I can jump in there, I think one of the opportunities is to look for, for example, we built this volunteer patient program at Hopkins for many years, where we'd have our trainees examine real patients with real findings, very similar to what they do in the UK, except it was a formative assessment. And now that we have the ability to analyze large volumes of data in the EHR, we can imagine a state where we could look at your EHR behavior, clinical decision making, even your movement in the hospital. We've done studies with tracking badges, understanding physical behavior in the hospital. If we can associate those signatures with clinical skills, we might be able to imagine a state in which you can identify, based on someone's EHR behavior, someone who might be in need of additional coaching for some aspect of their clinical skills, history taking, physical exam, management reasoning, whatever it might be, and then take these high resource intensive assessments and deploy them towards the folks who are more likely to benefit. But in order to do that, we need to actually make sure that the primary data we're gathering relates to what we're actually doing with patients. And, we've tried doing this with simulation. We've tried doing this with, the cardiovascular exam is probably the best example of this. We had 70 of our trainees take a very well-validated online cardiovascular assessment where you watch videos of patients with cardiovascular disease. You can move the stethoscope around. You can get hemodynamic data on them. And then we had them examine a patient with real cardiovascular disease, and there was absolutely no correlation between how they did on this computer-based simulation and what they did when faced with a real patient. And so I think we need to be really careful that whatever outputs we're looking at, we ground them in actual observations of what we do with patients at the bedside using AI tools or not.
Well, I think what I'll do is I'll move us on to kind of our last set of questions. And I think this will get to some of the questions that are coming up in the Q&A about like how to responsibly implement AI. So my question to all of you is if you could implement a policy or an innovation today to improve its use or think about its use, like what type of policy would you kind of suggest?
I'm happy to take the first pass. So I think you say I like the term, Brian. You said assessment may or may not drive learning, but drives attention. I like that phrasing. But to that point, I think there's kind of the thing to kind of acknowledge is there's resource differences, right, across institutions, right? And so I think something that helps drive resource advocacy is if there's external regulatory kind of governance of like this thing has to be met, and I think that's definitely something that is a challenge here in this landscape, right? And a lot of the tools and things we're talking about require internal HIPAA or FERPA, when it comes to trainee data instances to be able to build these things, right? And a lot of institutions don't have that access. And so if there is sort of external regulatory bodies, and obviously on the education side, that would be LCME, ACGME, of like this being core competencies or requirements that's in our education programs, in our assessment programs, it gives the leverage to kind of lobby, well, we need obviously the infrastructure and the resources to do this. And obviously then institutions themselves have to have policy around this of, guardrails, what can and can't be used at what stages. And that's stuff we have to figure out and certainly work together, not work in silos as educational institutions. But I think it is helpful if there's that external drive to be able to get the resources, particularly for if places are struggling to get those resources they need to set up this infrastructure.
Certainly thinking about HIPAA, FERPA, when it can and can't be used, policies around that. Holly, what do you want to add to that? And maybe Eileen, if you're able to take, it looks like Holly put a reference in the chat, and then maybe just if we can move that over to the Q&A if possible.
Yeah, so I wholeheartedly agree with what Barry said. We at Stanford really have thought kind of long and hard about the HIPAA and FERPA piece, and that is reflected in the policy, and that's why I posted it. It is about the responsible guardrails. That being said, it's incredibly hard to police this. And I think that comes up a lot for folks saying, I have no idea when my students are using AI. I feel like the policies often encourage students to hide when they're using AI because, if they're going to use it anyways, it gets into this gray zone of, well, if we told them not to use it in the policy, then they use it anyway. And we catch some of them, but we don't catch the others. I worry a little bit about kind of the fairness, the equity, the justice, like that lens of thinking about how we respond to students using AI. And so I do think it is actually it's in the role modeling, right? It's bringing it into the classroom and demonstrating how to use it responsibly. It's bringing it into the clinical environment in our practice of medicine courses or our doctoring courses and showing how perhaps we would use it. But then saying, we need to impart that it's really important for you to develop the skill set so that you have that robust base so that when you are at my stage and you're using it responsibly. This is how we work with it with our residents. I think it is in the transparency because yes, the policy is very important to protect patients, to protect learners, to protect privacy. and to put those guardrails in place. But then it's one thing to have the policy say it, it's another thing to actually live it out in practice and have that transparent conversation with our learners. So that we're role modeling using it responsibly, but also having these critical conversations with them about what it is that they need in order to do the same.
I think it's really important to think about what stage we're speaking of, because I think the policies are going to be very different based on where you are, what your practice is, what you're hoping to achieve, and and that it gets back to your question about how do we actually do effective research around this, right? Because you could imagine, well, if I'm going to be asked to sign off on the decision support tool, the AI decision support tool suggested this, imagine a future state in which maybe you're not actually seeing patients, but you're supervising the care that's being provided, at least for some conditions, maybe in the outpatient setting, that's being managed by AI. And if you yourself don't have the basic skills that go into clinical reasoning, how do you adjudicate what's right and what needs an additional review? How do you actually, who's responsible if the AI system makes a mistake that you signed off on? And so you could imagine, well, maybe one of the ways we do this is you have these algorithms running in the background for an early learner. They suggest their own differential diagnosis. And then after they've actually gone through that clinical reasoning process, including data gathering, then they're able to interact with the AI tool that maybe suggests a few things that they've missed. I mean, that seems like that would be a reasonable way to go about it, but we need to study that. I have no idea if that's the right way to roll out these tools, or maybe it works better if you start doing it, your first problem-based learning session, you have access to whatever AI tool that you want. And maybe that allows you to start seeing earlier on. I wish I could go back and take anatomy now because it would be a lot more relevant to me now. Because when I first took it, I had no idea why I was memorizing these structures and that structures. And there's lots of, as a pulmonologist, there's lots of structures in the chest that I've probably accidentally poked with a bronchoscope that I wish I had understood better before I started doing that, right? So I don't know what the right way is. And so I think it's hard to, it's really hard for me to speak about what policies might work without actually addressing that research question, because I don't know what the best way to learn what these tools are. And I certainly don't know the best way to take care of patients with these tools yet.
It brings up for me, going back to the research question for a moment, as you were all talking, I was thinking about research agendas and like the questions. I think it might have been Holly who pointed out, like the impact may be different. And Brian, you just mentioned it by like the type of learner. Also thinking about, are we comparing like AI to not using AI? Or like Brian is that example, like, are we comparing AI where you get it right from the beginning versus AI where you think on your own first and then you get to use AI? So like how we integrate AI as opposed to, the presence versus absence of it. And then also I was thinking about when we were talking about the research, we could ask questions about like, how did it help you with this differential diagnosis in this patient coming in with shortness of breath? But like, is that the outcome that we want versus the more like distal outcomes that happen, 6 months to a year from now? The other thought, as we were all talking about role modeling, is I think some of our learners may be like more ahead in this space than many of our faculty. And so maybe just before we move to the Q&A, what medical schools and clinical training should be doing now to kind of prepare both our faculty and then, to the degree that you want to answer, like students and residents.
We can't put our heads in the sand, which is why obviously you're not, of course, why we're having this conversation. And it needs to be a full thickness. And I'd say it's like the trainees might be more experts in the technology, but we as faculty are still like have the clinical expertise, right? So it's like the perspective of, and not like what we know about educational theory of what might work and what might not work. And, there's a whole kind of clinical reasoning of like structure reflection literature, what works and doesn't work. And to not forget about all we've learned in education. And while we're building, and obviously there's lots of research questions we need to answer and build those studies, but apply what we do know and extrapolate that, right? Because we can't be like, wait, you can't use it until we answer these research, questions. And so do the best that we can, best practices based on what we know today, which is going to be different a few months from now. It's going to be different 6 year, whatever. And we really need like tons of faculty development, around this, because yeah, the trainees are going to just up and up, having used this throughout their educational experience more and more so. Used in undergrad, used in K through 12 are going to be coming up soon enough. So it's not teaching them what's a prompt, right? Or what is this technology, but it's like, how do you do this to make the best outcomes in patient clinical decision making or make you a better communicator? And again, we bring as faculty that expertise. Granted, we need to know the AI piece as well. So we got to get our faculty up to speed here.
There's a question from the audience. I'd love to hear how you think UME and GME should go about teaching AI use, ethics, downfall. This is not a small question. I see it currently. I'm a fourth-year student applying into a generalist field, and there's no standard practice, and most information disseminates word of mouth through the house staff and the trainee population. So I know a pretty big question, but Holly, you unmuted, so I'll let you go first on that one.
Yeah, I'll give that one a try. Yes, infinitely aware of Reddit, Student Dr. Net, the word of mouth, how learners learn these days, all of the things. And I think I keep going back to this idea. It's about transparency. I think this is being very clear about how we as faculty use it, about how, our residents are using it, about what responsible guardrails are, et cetera, et cetera. But I also think, you talk about ethics and downfalls. We've been using M&M and case-based learning since the dawn of time. And so why would we not incorporate AI and kind of the iterations of AI and the things that have gone well and haven't gone well into that process? And I will say that example of, a resident putting in a completely wrong prompt, getting a completely wrong output for the patient in front of them, and maybe not necessarily realizing it until the faculty member stepped in and said, hey, actually, what did you put in as the prompt? Here's what you should have put in as the prompt and what would have given you the output you were after. Like, that's a good example that everyone can learn from. We've been trying to do AI-based triage in the emergency department at Stanford for a couple of years now. Where is that going wrong? Why is it not live? I will tell you a lot of it has to do with cultural sensitivity issues and the ability to detect sick versus not sick in patients who are not traditionally elderly Caucasian individuals. And so having the ability to reflect on the spaces where it's not necessarily working, why isn't it working? Or when open evidence, gives you the wrong answer to a clinical question, and taking those cases back to, learners and to faculty and saying, here's the possibilities. Yes, you should use it. Here's the responsible guardrails. Here are the pitfalls. Here are the ethical considerations, and showing kind of that balanced view, I think is important. I don't know that any policy or uniform response is going to be, kind of wholesale applicable across every program, every school, every context, because context matters so much to this. So having those critical conversations and being transparent about AI use within your context, I think is going to be very, very important. And we should be adopting that kind of in every program, school, et cetera.
Oh, sorry, Verity.
The only thing, and I think I agree with everything Holly just said, and I think the only thing to add to that is like agreeing on what are the core competencies here, right? And there definitely is some articles out there, and I know the AAMC has a working group, put together right now of like defining like what are the core competencies, and then we need to. I mean, we shouldn't wait for those to come out to build curriculum, but obviously that will help us refine our curriculum of like what are the skills, right? And then we need to roll out curriculum with those core competencies in mind. And as we said before, curriculum in the full thickness, right? Faculty development, GME, UME, and really have that be our guide of what we are teaching is what are the outcomes we're looking for here.
So I was just thinking about, and this analogy doesn't, I'm going through my mind, where does this analogy kind of lead us astray? But when I was a pulmonary fellow, David Feller-Cotman at Johns Hopkins, who's, trained so many different folks in interventional pulmonology, he established his program at Hopkins and he trained all the fellows how to do ultrasound guided thoracenteses. And the next year, when I was still a pulmonary fellow and I was on a rotation with a different attending who wasn't David Feller-Cotman, there were multiple situations in which I was confident and competent to do a procedure that my attending was not credentialed to do. And that created a very real tension, right? I would not want to be the supervisor of someone who's doing a procedure of which I am not trained to do. And so it forced us to grapple with, well, how do we rapidly either train more faculty or create a system in place such that the faculty who had that capability to supervise trainees was available when those issues came up. And I know this is not exactly analogous to the use of AI, but I think it reminds me that we don't all have to be experts in AI. We don't all have to be David Feller-Cotman in terms of our ability to ultrasound guided procedure, but we need to recognize when its use is likely to be helpful, when it's appropriate, and also recognizing when maybe we're not the right person to be in the room to guide that specific procedure if we ourselves have not had that experience. So I think the reason I brought this up is I think the solutions to that problem are going to be very context dependent, not just for learners, but also for institutions. I think Verity said this earlier, like the need for specific resources might mean that at certain institutions right now, there might be a different solution at one institution versus another based on what resources are available, based on faculty expertise, based on that individual context. But I do think it's important to remember that we've had these disruptive technologies, maybe not on this scale that we've seen before across all of society at once. But in medicine, we've had disruptive technologies before, and we've had this same conversation. How do we train our trainees to do something and use this new technology when only a fraction of faculty are themselves comfortable with that new technology? So I think we need to make sure we don't forget about how we've tackled these problems in the past as we try to come up with solutions moving forward.
Well, there's maybe one more question that if we can quickly get to it, and then I'll just do a quick wrap up. There have been some questions about just transparency, whether we as teachers should be transparent when we are using it, whether learners or applicants should be transparent when they are using it. So just any quick thoughts about transparency.
Yes. This is a quick,
Like
yeah.
All right.
But yeah, no, seriously, right? It's like we should, right? Because again, I think some things are brought up with like the role modeling. This is how I use it, right? We're using it this way in assessment, right? Like that's the only way you're going to build trust in the system is having transparency and talking about it.
Yeah, and I think one of the, I was at this conference this past weekend where John Kugler from Stanford's talking. He thinks a lot about how we use the electronic health record. And why is the intern reading the note on rounds when everyone has access to this record? But he said something that I thought made a lot of sense. It's that we always try to model how we deal with uncertainty. And one of the most powerful things that you can say as an attending on word rounds is, I don't know, right? But we're now in a position where it could be, I don't know, and let's look it up together right now, right? And that could involve an AI tool in the right context, right? And so we should absolutely be transparent. We should be modeling the use of these tools. We should be figuring out together with our learners and being comfortable saying, you guys are probably better at this tool right now than I am. So let's work through this together. You can teach me about the prompts and I can give you a little bit more of the context information that I've gathered from being in the room with that patient, right? So I think we need to make sure that we're collaborating with our learners about how best to use these tools, because I think Very said it right, that in many cases they're going to have a lot more facility with these tools than we ever will. But we have the clinical context and the educational context to be able to help them, use these tools more effectively and help us learn how to use these tools more effectively.
Then we'll think about our transparency with patients. So thank you to our incredible panelists for sharing their insights and for everybody joining us today. We clearly have a lot of work ahead of us as medical educators. It's pretty clear that AI will continue to be a part of medical education. This conversation was really important, and hopefully, I know we didn't get to all of the questions in the chat, but we'll look for other ways to connect as a community to continue to sort of move these ideas forward. We encourage everyone to stay connected, share their ideas, and collaborate. As a reminder, the session is recorded. We will share the link with you soon. It will also be available on the LDI website. And on behalf of the organizing team, thank you, Holly, Verity, and Brian, for joining us today. Thank you to the LDI for helping us to host, and thank you everybody for joining us.